Hi, hello friends. I'm Srikanth, physical therapist. Today we'll discuss about peripheral nerve lesions. What are peripheral nerves? The neurons which are arising from the anterior cells of the spinal cord towards the periphery, towards the motor end plates, we call it as a peripheral nerves. So, what are the reason for a peripheral nerve lesion? It may be a traumatic injury, or maybe because of the infection, or maybe because of the tumors which is compressing the nerve. Sometimes metabolic disorders like a diabetic neuropathy. So these are the reasons causing the peripheral nerves to get damaged. Based on the Shannon's classification, the peripheral lesions are classified as neuropraxia, axonotmosis, and neurotomosis. Neuropraxia is a compression of the nerve. There is no anatomical discontinuity, but functional disruption will be there. But in case of axonotmosis, is a partial degeneration of the nerve. Again, this axonotmosis is classified three types. First degree of axonotmosis, the axon is severed and endoneurium is preserved. And in second degree of axonotmosis, axon discontinuity, endoneurium and the perineurium and fascicular structures will be intact along with the epineurium. In the third degree of axonotmosis, there will be discontinuity of axon, endoneurium, vascular structures, perineurium, and epineurium. In neurotomosis is a complete degeneration of the nerve. There is a continuous anatomical discontinuity will be there. For a nerve to get degenerated, it will take 21 days. When we say the nerve gets regenerated is, there is a test called Tinel sign. When you tap along the nerve course from distal to proximal, the point where the person feels tingling sensation, it indicates that regeneration started. What is Wallerian degeneration and Wallerian regeneration? Wallerian degeneration is when there is a cut across the axon fiber, the myelin sheath undergoes degeneration, the axon undergoes degeneration, disappears from distal cut end to the next node of Ranvier, proximal to the next node of Ranvier. So what happens in the case of Wallerian regeneration is the Schwann cells multiplies and form the column of the cells and clear the area of debris. At the proximal cut end, numerous collateral buds will be formed, which migrates every 2 mm to the next node of Ranvier towards the distal cut end if there is no soft tissue interposition in between that. So, what is our role? What is the role of the physiotherapist in case of peripheral lesions? Normally, if it is based on the components. If it is a motor component is involved, what will happen? If the sensory component is involved, what will happen? If the autonomic component is involved, what is happening? If the sensory component is involved in the nerve, the person will complain of pain, tingling, numbness will be there, paresthesias will be there. Dysesthesia, sometimes dysesthesia is a burning sensation in the feet and the hands, and it will move upwards. If the motor component of the nerve is involved, there will be muscle wasting. Initially, there will be muscle wasting will be there. Later, muscle weakness will develop. Later, tightness in the muscle, contractures will develop in the muscle and the soft tissue. If the contraction is more than 30 degrees, we call it as a deformity. If the autonomic component of the nerve is involved, we can see the anhydrosis. There will be absence of sweating will be there. So what is our role? In physiotherapy, we have a tense. If the person is complaining of a stabbing type of pain, pin pricking pain, and if there is a what we call pin pricking sensation along with dysesthesia is there, we will go with a if there is a neuropathic pain, we will go with the tense. Tense transcutaneous electrical nerve stimulation. With the tense, the neuropathic pain will be relieved. And if there is a compression of the nerve, we'll go with ultrasound therapy. The nerve compressions will be relieved with the ultrasound therapy. And if the motor component is involved, if there is a muscle wasting, muscle weakness is there, we'll go with the, and if the power is 0 or 1, we'll go with the passive movements to maintain the joint range of motion, to maintain the muscle properties. And sometimes we'll go with electrical stimulation, neuromuscular electrical stimulation to maintain the muscle properties. And the splints are very important to maintain the limb in a functional position to prevent the overstretching of the unparalytic muscles. And we will go with the re-education board exercises, and we'll go with electrical stimulations to maintain the muscle properties. So as a physiotherapist, splinting, passive movements, electrical stimulation. If the person is complaining of pain, we'll go with a TENS, transcutaneous electrical stimulation, to relieve the neuropathic pains. Thank you.